Today, we'll be learning about the indications and complications of tonsillectomy. So, what is tonsillectomy? Tonsillectomy is a surgical procedure that removes the palatine tonsil entirely along with its capsule by dissecting along the peritonsillar space between the tonsillar capsule and the muscle layer. So, what are the indications for tonsillectomy? The most common indication is recurrent tonsillitis. That is, the child is getting recurrent attack of tonsil infections. So there is a criteria to diagnose if the child is having recurrent tonsillitis. So the criteria name is known as Paradise criteria. In Paradise criteria, we do a tonsillectomy if the child is having more than 7 episodes of tonsillitis in the 1 year, or more than 5 episodes of tonsillitis per year in the past 2 years, 2 consecutive years, or more than 3 episodes of tonsillitis per year for the past 3 years. So, what is an episode? If simply if the parent comes and say we had 7 episodes, can you take it for the criteria? No, all the episodes has to be documented. Each episode means the child is having a sore throat plus the following criteria: a sore throat plus there should be a in fever, that is increase in the temperature or recorded temperature more than 38 degrees Celsius or 100 degree Fahrenheit. There should be any cervical lymphadenopathy, or there can be some tonsillar exudates, that is slough is forming over the tonsil, or there can be a swab that is positive for group A beta hemolytic streptococcus. So that is an episode. So 7 episodes in the last 1 year, 5 episodes per year for the last 2 years, 3 episodes per year for the last 3 years. You can go for surgery. Also, in recurrent tonsillitis, there are some other indications like if the child is not tolerating antibiotics and child is not able to take the full course of antibiotics, child is having severe allergy. There is another condition known as periodic fever after stomatitis, pharyngitis, adenitis. In such children, we recommend tonsillectomy so that the children will not get sick recurrently. Another indication for tonsillectomy is sleep disordered breathing or obstructive sleep apnea in adults. The sleep disordered breathing is because of the enlarged tonsil. The airway is partially or completely collapsing when the child or adult is sleeping. So there will be snoring, and then there will be daytime sleepiness, irritability, inability to concentrate on the work. In children, there will be failure to thrive, nocturnal enuresis, growth retardation, poor school performance. All this can be seen as a symptom of the obstructive sleep apnea. So we have to evaluate for that, do a polysomnography and a DICE examination and find out the obstruction and can proceed with tonsillectomy. Another indication is in children, tonsillitis causing febrile seizure. That is, the child get an attack of tonsillitis, child gets fever, and child is getting seizure. So we do a tonsillectomy for such children. Another indication is peritonsillar abscess. That is a pus collecting between the peritonsillar space between the tonsillar capsule and the superior constrictor muscle. So in such cases, the patient is initially treated with antibiotics or an IND if required, and the peritonsillar abscess has to subside. And after 4 to 6 weeks, a tonsillectomy is performed so it does not recur. So that is known as interval tonsillectomy. Then another indication for tonsillectomy is if you are suspecting a malignancy. So if there is unilateral enlargement of tonsil, we do it as a part of excision biopsy. We do tonsillectomy. Other related indications for tonsillectomy is chronic tonsillitis with halitosis, tonsilolith. Then certain people who are carriers of diphtheria and streptococcus who are not responding to medical treatment, we can do tonsillectomy for them. And also tonsillectomy can be performed as part of other surgeries like palatopharyngoplasty, glossopharyngeal neurectomy, in removal of styloid process, etc. To approach the styloid process, you can do a tonsillectomy. What are the contraindications to do a tonsillectomy? Main complication of tonsillectomy or any surgery is bleeding. So in children, if there is any bleeding diastasis, it is a contraindication. So we have to evaluate for any hereditary bleeding problems, swan deliverance disease, hemophilia, and full blood count. Everything has to be done before preparing the child for surgery. Other contraindications are any fever, acute infection. We usually do not do a tonsillectomy when the tonsil is acutely infected. Then small children, less than 3 years, in anemic children, that is HB is less than 10 gram percent. In children with other anesthesia risks, like children with heart disease or the congenital heart problems, all these kids we have to evaluate and be prepared for the anesthesia risk and then proceed with surgery with caution. Another contraindication is we do not perform a tonsillectomy in an epidemic of polio. The epidemic of polio is not going to happen in India because India has eradicated polio. If you operate in an epidemic of polio, you are creating a opening on the mucous membrane of the respiratory tract, so the virus can enter and it can cause bulbar polio and respiratory paralysis. What are the complications of tonsillectomy? As I said earlier, the most important complication of tonsillectomy is bleeding or hemorrhage. So the bleeding occurring during the surgery, that is known as primary hemorrhage. It occurs during the surgery. Second type of hemorrhage is reactionary hemorrhage. So reactionary hemorrhage occurs within 24 hours of the surgery. It usually occurs due to if you have put any ligature, it has slipped, or if a small clot has formed and superior constrictor constrict the tonsillar fossa and prevents any bleeding. So the clot can prevent the superior constrictor from constricting. All this can cause reactionary hemorrhage. So reactionary hemorrhage occurs within 24 hours. Third complication is secondary hemorrhage. Secondary hemorrhage occurs 24 hours after the procedure. So any hemorrhage occurring 24 hours after tonsillectomy is secondary hemorrhage. Usually, secondary hemorrhage occurs 3 to 5 days after tonsillectomy. You know that after tonsillectomy, there will slough will be formed. If the tonsillar fossa is getting infected, it can lead to secondary hemorrhage. How do you manage a tonsillectomy hemorrhage? Before taking up the patient for surgery, make sure that the patient is well prepared. That is, the tonsil is not acutely infected, and all other comorbidities, any heart disease, any bleeding disorders, anesthesia, checkups, everything is done and properly prepared patient. This will help you reduce the amount of primary hemorrhage. If you take an acute tonsillitis patient for surgery, that is known as hot tonsillectomy, the chance of primary hemorrhage is more. On table, you can apply pressure into the tonsillar fossa, pressure compression to reduce the bleeding. Also, you can use suture ligatures. Usually, you use useful, and electrocautery can be used. Bipolar cautery can be used to control the primary hemorrhage. Reactionary hemorrhage, post tonsillectomy hemorrhage is a surgical emergency. So it has to be evaluated fully. Most often, the patient or child is made to sit up and you evaluate the bleeding. Make sure that an IV line is secured and all vitals are checked immediately. And if fluids are started, you can give drugs like tranexamic acid to control the amount of bleeding. If it is a minimal bleeding or a small clot, no active bleeding, you can give mouth gargle, cytosine peroxide mouth gargle, apply directly pressure of the tonsillar fossa using a gauze and wait for the bleeding to stop. Closely observe the patient, especially children. Children may not know that they're bleeding. They might be keeping on swallowing the blood. So you have to observe the child in the lateral position, that is post tonsillectomy position. If the bleeding is severe, we might have to shift the child to the OT, find the bleeding point, use sutures to ligate, or you can use electrocautery. In certain cases, you will have to do a pillar suturing, that is, suture both the anterior and posterior pillars together to arrest the bleeding. So secondary hemorrhage is basically due to an infection. So you have to admit the patient, give IV antibiotics, give tranexamic acid, and if it is a major bleeding, you will have to shift the patient to OT. Also, in the children with reactionary hemorrhage might have swallowed a lot of blood, so blood will be in the stomach that has to be evacuated out. You usually use a Riles tube and suction out the blood from the stomach also. What is post tonsillectomy position? Post tonsillectomy position is lateral position, right or left lateral. Usually, left lateral is preferred. The child or the adult has to lie in the side so that the mouth will be slightly open, and if any bleeding is there, it will come out rather than going into the larynx or the lungs. Other complications are if there is any infection of the tonsillar fossa post tonsillectomy, it can lead to parapharyngeal abscess. During tonsillectomy, we put the mouth gag and also there can be injury to the lips, teeth, buccal mucosa, tongue, etc. can be injured. Sometimes the anterior pillar can be injured, soft palate can be injured, which can heal by scarring. If not properly monitored, during the procedure, child can aspirate the blood into the lungs and causing lung problems, lower respiratory infections, atelectasis, etc. Now coming to a common viva question, what is Grisel syndrome? Grisel syndrome is non-traumatic subluxation of the atlantoaxial joint, that is C1, C2 vertebra. So it is mostly seen in children with ligamental laxity around the neck, especially in children with connective tissue disorders and Down syndrome, etc. After the surgery, the child can present with neck pain, torticollis, that is neck stiffness, and fever. It is said that there are many contributing factors. The ligamental laxity is a contributing factor. Plus, there can be associated inflammation of that area due to the infection of the neck. Plus, in tonsillectomy, we use a rose position. So, manipulation of the neck can also be a contributing factor for the subluxation of the C1, C2. Another relative contraindication for tonsillectomy can be a submucous cleft palate. So there is a cleft palate. So the tonsil is there. In such children, adenoid may also be there. So if you remove the adenoid and the tonsil, the cleft palate will be less supported, as there is only a mucosa lining the cleft. So the child can have velar-pharyngeal insufficiency. So the child can have difficulty in speech and swallowing post the surgery. The details of velar-pharyngeal insufficiency I'll be doing in another video. So primary hemorrhage, reactionary hemorrhage within 24 hours. After 24 hours, it is secondary hemorrhage, injury to other structures, lips, tongue, buccal mucosa, teeth, etc. Then if there is any aspiration, it can cause lung problems. It can heal with scarring, causing scarring of the soft palate, and also anesthesia complications.